My answer is, in a perfect world, everybody should be genetic tested for prostate cancer patients. Everybody wants to know what they have. There's some people that could have a BRCA gene that would be very informative to know even in early stages. The limiting factor is that the insurance companies do not recognize this at all. And there are even patients who have aggressive disease and multiple relatives with prostate cancer who get turned down for genetic testing by the insurance companies. So in a perfect world, as a urologist, everybody who's diagnosed, I would for sure want to know their genetic situation. Especially, it's going to be more and more important as we go forward. We're going to learn things we never knew before, and I think it would change how we approach prostate cancer patients if we knew about some of these other people who had genes that we would never have suspected to check for. So I think that the insurance companies are still the rate determining step on this. We can do everything we can to push patients to get genetic tested, but if it's going to cost them $1,500 out of pocket, we're going to have trouble getting it done.
So I think genetic testing as a whole is underutilized, but in prostate cancer, if you want to just imagine, prostate cancer is the second most cancer in men, and it's the fifth leading cause of cancer deaths in men in the world. It is underutilized because, number one, most patients may not know their family history. So to add to Dr. Korman's point, if you rely just on family history and stage of prostate cancer, you may miss a significant proportion of patients who may be eligible for non-chemo based. It is not just one, how we treat the prostate cancer. Let's say we have a patient whose prostate cancer does not need treatment at this point in time. If we know that they have a genetic mutation, which is likely to make their prostate cancer behave more aggressively, we're likely to change how often we screen them, or surveillance protocols are implemented for looking for progression. So it also helps understand progression in this person with prostate cancer. What is the risk of metastases? Is this person a candidate for newer therapies, either now or down the road, that specifically target the mutations? And it's important for us to understand what other cancers this person could be at risk for, and whether other family members are at risk for cancers as well. So one is counseling the patients, and that's where this urology group stands out, because as soon as information regarding genetic testing came out, they came up with a protocol whereby patients who are at high risk would be identified and counseled appropriately. A lot of times patients do not undergo genetic testing because of fear of what if I find an abnormal gene. So if you can explain to them, listen, if we do find an abnormal gene, these are the things we can do to help you and to help your family, you're alleviating a lot of the fear associated with not testing the patient or why the patient is reluctant. Number two is making sure if they fall within the guidelines for testing, making sure that insurance is aware, hey, this is the reason why I'm testing. And again, I applaud Dr. Korman's group because they went and asked the patients a detailed family history so they could do everything possible for insurance to cover it. And if insurance doesn't cover it, they gave the patient the option of choosing to pay out of pocket, but kept the dollar amount significantly low so it could become affordable to more patients than not. So that's what I would recommend as an oncologist. Dr. Korman, please chip in as the person who came up with the protocol, how you went about it.
Yeah, so the other direction is doctor education. So doctors are busy. We are overwhelmed in the office. We have charting and audit requirements, and we have lawyers looking at our notes, and we have the insurance companies looking at our notes, and everybody's under pressure just trying to get people in. We're being cut in our reimbursements all the time and asked to do more at the same time. And where everybody else is getting bailouts in the economy, our prices we cannot raise, but we're paying more for our employees and our supplies and everything else that's going on. So to ask our doctors to take a stop and spend an extra 5 to 10 minutes with the patient, talking to them about genetic testing and the ramifications, and it opens up a whole nother can of worms in terms of what's going to happen. They have to be facile in it so they can answer questions quickly and know the answer to it. And then they had to know how to do the resources. So there's a huge doctor education portion of it. And it probably would be something that would be well spent with a mid-level provider, could be taught to do this, and they could, see every patient if they're diagnosed with cancer, and they could assess that. I think that would be a good use of the resources. But the problem is, again, resources cost money. So our screening, we had our MAs doing intake questionnaires and our doctors looking at them. This is all, these are employees that could have been used for other purposes. So we have to look at the whole financial market. And if we're not being reimbursed for it, because we're not doing genetic testing in the office, we're not the ones lowering the prices, we're just offering it to our patients. Something's got to give there. And whether it's the insurance companies giving us, could there be a code, a modifier that we use that we discuss genetic testing and they give you an extra $50 for doing that, and then that could be applied? Could we get paid by the insurance companies for screening patients, $5 a chart that we screen and take the history? Something's got to give. It's not a zero-sum game. And the doctors are always asked to shoulder the financial burden for everything while not getting assisted from the government and everywhere else that is getting assistance.